All right, everyone, welcome back to the N3C Community Forum. Hope you all had a wonderful summer, and it's great to be back and have everyone join us. Next slide, please. So just to go over the ground rules, all the presentations are recorded and archived on the N3C YouTube channel, so you can check them out if you want to get the finer points afterwards or forward it on to other folks. And if you have a question, please post it in the Q&A. We will be monitoring it throughout. And if you would like to be unmuted and ask a question live, then go ahead and raise your hand and we can unmute you. And for next month's forum presentation, we're going to be talking about COVID reinfections, and Richard Moffat and Emily Hadley will be presenting. And now on to the main topic for today, how TEFCA improves access to clinical health data. So if you're like me, a clinical informaticist, you are definitely wondering how TEFCA impacts your work. So by that, we mean the Trusted Exchange Framework and a Common Agreement. So with us today, we're very lucky to have Kathryn Bingham talking about this important topic. She is the Vice President of Interoperability Adoption at the eHealth Exchange, and she spent over 30 years in leadership positions on both the provider, payer, and healthcare technology sides. She's been a CIO for hospital systems and managed care organizations, and also the Vice President, General Manager of Division at Cerner. So without further ado, welcome, and I will turn it over to you. Thank you.
Yes, thank you so much. I appreciate you all taking the time to attend today's session, and hopefully can provide some good information. And if you have questions I can't answer, I will get those answers to you. I'm going to go off video so I can share my screen, and we can get started. All right, so the eHealth Exchange is a network. It's a group of healthcare organizations who've agreed to share detailed patient-specific clinical information. And we're the oldest and largest health information exchange in the United States. And in December of last year, we were designated as a QHIN, which is a Qualified Health Information Network. And so what the kind of data that's exchanged with who you can exchange with on eHealth Exchange is there's 5 federal partners. We have the FDA, the Department of Veterans Affairs, U.S. Department of Defense, Indian Health Service, and Social Security Administration. And then 75% of all hospitals and health systems, 58 state and regional HIEs, and then we have 64 public health jurisdictions. And so one of the interesting things about this is that all of our participants have signed the same trust agreement, and it's called the Data Usability and Reciprocal Support Agreement, or DURSA. And because that arrangement is between all of our participants, no one can redline anything. Everyone signs the same thing. So the FDA signed the same thing that Kaiser did, that CommonSpirit did. And, you know, we started with federal agencies at our roots, but we found that the HIEs provide great foundational exchange capabilities that tie into a national solution. And so they can help close those gaps of care. And we also are using networked FHIR, and that's the only way that we're the only exchange that is using FHIR to scale nationwide. And then we've also added payer exchange for burden reduction. So the participating HIEs, they're all over the country with a couple notable exceptions. The only HIEs with query and retrieve capabilities that are not participating in eHealth Exchange are Greater Houston Health Connect, One Healthport in Washington, Idaho HIE, I think they're in bankruptcy, Healthy Connections in New York, and Health X in New York. But all the others are participating. So we were incubated by the U.S. Department of Health and Human Services in 2006. And the initiative ended in 2012, but the participants felt that the exchange was so beneficial that we privatized as a nonprofit organization dedicated to the public good. We don't, we do not have shareholders, we don't have venture capital supporting us, nor vendor support. We're all self-funded through our fees, and we try to keep our fees as low as possible to encourage that interoperability. We're governed by the federal agencies, providers, and HIEs that are our participants. And so I don't make any decisions about which direction we're going. That is done by our coordinating committee. And we don't save any data to track where patients have been. And there's no data repository to attract cyber criminals. And the kind of data that's exchanged, we have all of the things that are normally included in the CCDA, or Consolidated Clinical Document Architecture. So things like history and physical, discharge summary, operative notes, procedural notes, lab results, and all those kinds of vital signs and plan of care. We also do reporting on adverse events, electronic case reporting, and then facilitating in that burden reduction with prior auth, and being able to determine health information requirements for health insurance. So we have a content testing program as well, and we're the only network that I know of that does this, and it's required for all participants. And so not only do we ensure that the transactions are flowing appropriately, but that the data is structured correctly and that the right codes are being used. And although we have been doing FHIR exchange for about 2.5 years, we haven't had we were doing that with the FDA. We have not had a content testing program, but I'm happy to say that that testing program is live in a proof of concept environment now. And so we can have those same kind of standards for ensuring data quality that we do for the normal HL7 transactions that have historically been exchanged. So we support a large number of use cases. So we have the treatment, care coordination, and public health queries, and that is the vast majority of the exchange that's being done on eHealth Exchange. And when somebody requests information for treatment, they have to respond if somebody requests information on a patient from them. We have that clinical data exchange between providers and payers, and determining whether prior authorization is required, being able to have clinicians to receive near-time decision support by embedding the prompts and messages in their EHR. And we support Social Security disability benefits determination, individual access to healthcare, life insurance, and then syndromic surveillance notifications. And so, like with the FDA's use case, they will get notification of adverse events post-COVID immunizations, and we're going to be expanding that to a lot of additional immunizations. The electronic case reporting, we've done a great deal, and during COVID, we expanded that to allow for the use of our trust agreement, the DRSA, to be able to allow many other organizations other than just eHealth Exchange participants to submit electronic case reporting. So we support in one way or another about 95% of all the electronic case reporting. And then we have encounter alerts where when in certain states, in California in particular, there's organizations that will automatically send when there's been the detailed clinical information about an encounter, when any of the patients have been admitted or discharged, and that is then shared with the HIE manifest medics. And then prescription drug monitoring program as well. We received a class points of light award, and we were very excited about that because we've been working collaboratively with payers, other QHINs, and providers to reduce that burden of prior auth and make sure that those cases are approved sooner so that patients can get treatment. And we did this all using FHIR. And so that's one of those things that we're encouraging the use of FHIR because it can get very specific on the kinds of information that is shared, the resources that is shared. So we have a single connection and trust agreement, and we use a hub and spoke architecture to establish bidirectional connections with all the participants. And it allows participants to use a single set of APIs to connect with everyone else. Right now, we're doing about 22 billion transactions annually. And it's our centralized system that serves as a shared gateway across all participants and to other networks. And it is not a data repository or warehouse. We're the pipes that allow for that connection. And then we also participate in 2 other networks. So TEFCA, the Trusted Exchange Framework and Common Agreement, and Carry Quality. And so through that single connection, if somebody who joins the eHealth Exchange can also have access to these 2 networks. We have done the work to become a Carry Quality implementer and to become a qualified health information network. And so the kinds of organizations that the other implementers on Carry Quality are all these organizations, these other QHINs. The only one that's not on Carry Quality right now is Kanza, and then the candidate QHINs of eClinicalWorks and SureScripts. So it allows for a lot more connectivity and broadens, from just most of the hospitals on eHealth Exchange are Epic, and so this allows for a greater reach and to get to some of those smaller organizations. And same thing with TEFCA. And now both TEFCA and Carry Quality are optional. And so you don't have to participate, but you can. And you can opt in or out anytime you want. And so here's all the other qualified health information networks and those 2 other candidate QHINs. And I think there's probably a pretty big pipeline of additional organizations that are going to become QHINs. It's been very well received. And so I'm now going to go into TEFCA specifically. And this is part of the 2016 21st Century Cures Act. And it requires an Office of the National Coordinator to develop or support a trusted exchange framework and trust policies and practices for a common agreement. And so very similar to that common agreement is very similar to our DRSA, the trust agreement. So really very similar conceptually. So the benefits of participating in TEFCA is it creates a floor. It's a nationwide approach for the exchange of relevant health information. And so rather than being primarily for treatment purposes, this can also support payment and operations, quality assessment, benefits determination, consumer access to health information, and public health. And so this common set of rules will reduce the burden that current health information exchanges face when you try to establish connections with entities outside of their networks. And the goal of TEFCA is to enhance provider and consumer access to health information that supports better clinical decision-making and improves outcomes and lowers cost. So for public health and state governments benefits, it improves that population health and it streamlines those pathways to public health. So it increases the number of entities using electronic means rather than paper, fax, or phone to create efficiency and allow for greater use of reported data to support analytical analytics and design of interventions. And so, right now there's we support that public health reporting for electronic case reporting, lab reporting, immunization, syndromic surveillance, registry reporting, and facilitating that bidirectional exchange. And one of our organizations right now, Pulse, does emergency preparedness, where if there's a natural or man-made disaster, they can access at the point of care, they can access credentialed providers and make sure that they're credentialed to be able to provide care, as well as getting information from all the medical records for anyone that is exchanging using eHealth Exchange. And so it also augments state level information exchange. So it's a less burdensome exchange for across provider types, including those that are not yet connected to exchange or with less sophisticated technology. And this is a slide that was taken from the RCE, which is a recognized coordinating entity on how TEFCA works. So ONC, the Office of the National Coordinator, defines the overall policy and general governance requirements. The RCE was what is a public-private partnership selected by ONC that governs the exchange that occurs under the common agreement. So they're basically a subcontractor of ONC, and they make sure that all the QHINs that have applied can do all the things that are required in the common agreement, and that they make sure that all their participants and sub-participants are doing the same thing. So Congress came up with this because they viewed a lack of trust and consistent technical standards as barriers to data exchange. And so TEFCA is created, is intended to create that common legal agreement and a common set of technical standards, which is called the QHIN Technical Framework, and that will allow for that trusted exchange. So the RCE selects and oversees QHINs, which make up the core of the network, and they are right now there's been limited exchange for anything other than treatment, and the hope is that this will broaden the exchange and really help with being able to get information that organizations can get today, but it's difficult because they have to request it, get the faxed information, and this really expedites that sharing of information. One thing that's really important is that the Cures Act specifically allows federal agencies such as CMS, Department of Defense, and the VA to require providers to participate in TEFCA. So that will spur many to join a QHIN that might not otherwise. So the technical exchange framework, or TEFCA, as it says in the title, it's a framework, not a network. So it provides technical and policy agreements, the governing structure, and a federated architecture, meaning that they don't do the architecture themselves. TEFCA doesn't do that. So it's similar to how the telecommunications industry has a behind-the-scenes framework allowing Verizon mobile phone users to communicate with T-Mobile and AT&T. TEFCA provides the policies and governance, enabling providers in one QHIN to exchange with providers on another QHIN. So the common agreement, again, is that trust agreement. And it's important to know, and this is a common misperception, that if you join TEFCA, you have to sign the common agreement. And that's not true. That's each QHIN has to sign the common agreement, but their participants and sub-participants do not. There's also another document called the Terms of Participation, which needs to be signed by all the QHINs. And that was created because there were many things included in the common agreement that they felt that might change over time as exchange evolved. And so they pulled some of those out and put that in the terms of participation to avoid having to have all the common agreement adjusted every time there was a change. So a really important part of this is that all the QNs have a responsibility to ensure that their participants and the participants, sub-participants adhere to all the flow down provisions of the common agreement. And so there's a number of required flow downs, and everyone has to follow the same rules of the road. And we do not have a great deal of exchange going on with TEFCA today. And that's because of some of these agreements. So if you think about all of this confidentiality and all this kind of information, and let's say you're dealing with an HIE, they have to make sure that every one of their legal agreements has these flow down requirements as well. So it takes a little bit longer. There's great support for TEFCA. It just takes a while to make some of those things happen. And that's really on the policy side. There's also challenges on the technical side, but the policy side's a biggie. So as I mentioned, there's that the participation agreement. And with that, all of those kinds of things have to be followed, and it has to be signed without modification, just like our DRSA. And so I'm going to go through a couple of these that I think are more important. But we have to, it's important that all parties cooperate in certain aspects of exchange, like timely responses to inquiries, notification of persistent and widespread connectivity failures, support in resolving issues, and sharing information regarding cybersecurity risks. And it's also important that each of the QHINs, their participants and sub-participants, can't limit interoperability with others in a discriminatory manner. The RCE directory is like an address book. And that sounds pretty simple, but it's not. And as Social Security, when they're onboarding new participants who want to exchange with them, one of the hardest things is to get the list of the organizations that they have. And so it's much more complex than it sounds. You can't have duplicative entries in the address book. And it has to be updated at least daily by all of the QHINs, so they keep a very close, so it's as accurate and up to date as possible. And from a privacy perspective, you have HIPAA, and that obviously is a guiding principle. And then the minimum necessary also provides guidance. So you want to make sure that a covered entity or business associate only is getting the information that they need. They don't get everything that is available. They only get what is appropriate for them to get in the circumstances. And that is simplified somewhat when we use FHIR, because you can request specific resources. So to guide a lot of these things, and I promise I will not go through each of these, there are standard operating procedures. Now, all of these are listed on the rce.sequoiaproject.org resource page. So if you want some light reading, you can find them there. But the SOPs, it's like, this is how you have to do each of these things. And in the exchange purposes, it outlines exactly how it should be done, what codes need to be used, all those kinds of things. And same thing with the privacy and security. There's a lot of detail there. For exchange purposes, there's treatment, and you can see of all these exchange purposes up there, there's only two that require a response. So right now it's TEFCA treatment and individual access. this TEFCA treatment is more rigorous than HIPAA. And so it's very specific for what kinds of providers are shared. Now, some of this has not been finalized yet, but these are the existing treatment exchange purposes that are published on the RCE website. Individual access, again, that's great. We hope that that comes about, and public health. And so, you know, you have your electronic case reporting and electronic lab reporting. Both of those fall under public health. There's also just a general public health. And right now, that's not required. Our hope is that that's very soon that some of those are required, so that people have to share that information if they're part of the QHIN. So like the SOPs, we have a QHIN technical framework, or QTF, which describes the technical requirements for QHINs. And we at eHealth Exchange have a document on our website that identifies the requirements for both eHealth Exchange and its QHIN participants. And that can be found on our website, which is ehealthexchange.org/resources. And so it's really important that participants in a QHIN understand some of these capabilities that they have to have. So this is the technical side. And so, you know, how you do connectivity and remediation, your mutual authentication, your user authentication, how patient discovery queries are done, and document queries and retrieve are done. And then, you know, the record location, and they allow a number of different ways that you can do record location. And so eHealth Exchange uses a federated model. So we push that patient discovery down to our participants, and they say whether that they have a Kathryn Bingman with these demographics, rather than us having a master patient index. But others, like Commonwealth, have a master patient index. So there's some differences there that they allow, but it provides those technical guidelines. The QHIN onboarding process, and this looks like, you know, okay, there's 5 steps, no big deal, but it, you know, took about, we were February of 2023 was when we put in our application, and then we were live, designated as a QHIN in December of 23. So it's not a short process, and there's a lot that goes into it. Obviously, you have your application submission, and then the review can take by the RCE can take up to 60 days. And then on the phase 3, applicants accepted for testing must complete the technical prerequisites prior to beginning conformance testing and non-production partner testing. And that conformance testing, like our content testing, is intended to be largely automated and have limited minimal manual review to verify that it conforms to the standards. And you also, each prospective QHIN has to complete a series of non-production tests against the test instances of the other QHIN gateways. So that it's quite a process. And then you have your designation and post-production testing, and then you are exchanging PHI. That's the final phase. So we were designated in December, and in January we were exchanging PHI. I am not going to go into detail on the metrics or the governing approach, because I think we've covered some of that. But the metrics are just, you know, the reports on response times, messages exchanged, documents, all that kind of thing, error rates. The governing approach, there's a whole SOP on that. And again, that's under the resources on the RCE website, so you can take a look at that. But it's basically, you know, who the structure, the committees, what happens when people disagree with other QHINs. Oops. So we've had new public use cases. This was announced by the Centers of Disease Control and Prevention, that we achieved a major public health milestone, the launch of the first 2 public health use cases for TEFCA. So there's electronic case reporting and public health query. So we were very excited about that. And so as of July 1st of this year, we started those 2 use cases. The individual query use case, the public health authority is made aware of a case to investigate, and then they use the HIE portal to query for additional information on the person. And so CRISP Shared Services is the HIE, and the public health authorities in Maryland, Alaska, and Fairfax County are the ones that are retrieving that information. The case reporting, the APHL, along with Washington State, Georgia, Indiana, Wyoming, Texas, and Oregon, started doing the exchange over TEFCA as well, which we're really excited about. The ECR volume, you can see that for the month of August, we had over almost 8.5 million electronic case reports going through eHealth Exchange. And so part of that, the QHIN was about 416,000. So it's about 5% of the total exchange right now. And all of the states were included in this mostly via eHealth Exchange rather than the QHIN, but really broad use of that electronic case reporting. And so today we're doing the electronic case reporting. We're doing that individual query by public health authorities, and then adverse events with the FDA. So adverse event notifications and supplemental data queries, and then Pulse, that emergency preparedness use case that I mentioned. And so, again, expanding those supplemental data queries is something we're going to be using. And then, making sure that this clinical records can enable case follow-up, and then provide plugins to accelerate the STILT, which is a state, tribal, local, and territorial public health connectivity with data networks, and then making sure that the patients aren't identified, but you can get back to the individual patient by using methodology like tokenization, such as PPRL, or privacy preserving record linking. And then electronic lab reporting. We're hoping, and the discussions we've had so far is surrounding using FHIR for the electronic lab reporting. Electronic case reporting right now is being done using the HL7 SOAP IHE profiles. This is a pull use case that we've done with the FDA. And so with that, the adverse event is reported to the FDA, and then they get those demographics for that patient, and then they provide an additional data request, and they get, using FHIR, they request and receive the FHIR data from eHealth Exchange Hub, and then that information queries for a patient match to the organizations that are in the patient state or adjacent states. And we're going to be moving that to hospital referral regions before too long. And then all that information regarding the record of the patient interactions will be included in the response. And what eHealth Exchange has done in the middle here is we've added some security work that really, it keeps it, first of all, it minimizes all the different connectivity you would have to do with all these different organizations, because we manage all those security differences. The other thing it does is FHIR can be very chatty, many transactions going back and forth. And what we do is bundle those up and then serve them up once instead of all the back and forth between the organizations. So that's a use case that I could see being of import for additional information for any other use of this kind of clinical information for follow-up. We also have, this is a slide that we prepared for the NEDS reporting, which is the National Electronic Disease Surveillance System. And so very similar to what I just showed for the FDA. They know there's additional information they want to get, and so they're able to do the FHIR queries and get a FHIR response and be able to do that reporting. All right. Well, I hope that gave an overview. I know some of that's a little dull, but it's kind of important to know what goes into becoming a qualified health information network and then supporting that.
Thank you so much. I think we had a question which we have a lot of researchers on the line, I think, and one of the questions was, can researchers in breast cancer, for example, join and gain access to de-identified data for research purposes?
Well, doesn't happen magically today because that's not yet a required use case. So that doesn't mean that you can't do it. It just means there has to be a conversation first. And so, if you're getting that information, if you're working with a organization and they are a e-health exchange participant, both parties need to be an e-health exchange participant, but yes, you can arrange that. And the FHIR is a much simpler way to do that because you have the FHIR endpoints and then you say, hey, I want this information. And you wouldn't ask for the patient demographic resources.
This was so wonderful. I have a gazillion questions. Thank you. It wasn't boring at all. And by the way, your slides are really quite wonderful and easy to follow. That's not an easy thing. So thank you.
We have a hand up from one of the attendees. I just had them allowed to speak.
I'm sorry.
Can you? Okay. We had a person who was trying to ask a question and they had a hand up and I.
Oh, I'm sorry.
No worries.
Do you want to let that participant go and then Ken right after that?
Yeah.
They disappeared from my screen, so I'll try to get them back.
So, Kathryn, this is a little also in the weeds. We are working with iHi and Sync Health in Nebraska, Iowa, and Indiana. And we're bringing in N3C. I don't know how much you know about it. We bring in this huge dump of information. And starting in 22, we started working with HIEs to start using it for research data. Originally, it was University of Illinois at Chicago and iHi, but now we're doing second round. And well, we have a lot of questions. First of all, originally when we started doing it, we had to use a CQL query to be able to query the data sets, and a FHIR query language was in development. And I was curious if you knew any updates on how mature it is. Another question is Bulk FHIR still feels a little bit, a lot of people kind of talk about bulk, but they're really doing one patient at a time, and they kind of not trick the system, but they say, just run through everybody and then use everybody's identifier and then pull this information. But for public health, we really need to be able to pull just bulk FHIR, not patient-based. So I'd love to know about that. And then the last question, I'm sorry, loading down, is we're very interested in linkage. We use PPRL, and so we're working with those two exchanges to bring in information on renal diseases and cancer disease, but we are linking them to CMS data and for cancer SEER registry and for renal to transplant registries, and I'd love for you to talk about how you all are thinking about doing linkages, because we just think it's so important to, you know, being able to really do research. So that's a lot. Thank you.
So the first one was how far along can you state that question again? The first one, I'm sorry.
Yeah, it was FHIR query as a language. We were using CQL because in 2022 it wasn't FHIR query wasn't mature yet enough to use. And I guess I'm asking that in conjunction with a true bulk return instead of CCDAs.
Yeah. Well, we're doing that. And bulk is, we're having discussions with organizations that are doing, want big amounts of data for public health. And so we're in discussions about the bulk FHIR, and I can get you some more information on that. I can't speak to it to a degree that I feel comfortable giving an answer, but with the FDA, and this is patient specific for the FDA, but it is a FHIR query. So they query for the patient and get that data back.
But it's always patient-based. It's not condition-based or lab-based. And
right.
That's what, for public health, we don't know the patient. Right. So anyway, that would be great if you had any information on it.
Yeah, absolutely.
I know it's been maturing quickly, but never quick enough.
Yeah.
Or, and the other question was really the linkage issues.
Sure. And I can get more information on that too, because we've had discussions on that as well. Numerous discussions on that. It's just, I'm not sure where we have landed from the technical aspect, but I know we have thoughts on it for sure.
Do you have any more information you can share with us on TEFCA 2.0 and its research initiative that's coming out in 2025, or is that still kind
it's still early?
Still okay.
Yeah, we're doing some review, but on some of these new things that they're bringing forward, but it's really more comment rather than anything firm yet, and we're not supposed to share it till it's firm.
All right, I won't. I think you'll have to kill me if you say anything, so don't. But this is really wonderful. Thank you.
You're welcome.
We have one question in the Q&A chat.
I'll go ahead and read that off. It says, are most of the exchanges initiated by providers or by patients or by government agencies?
Well, it's definitely the government agencies and providers. So the VA and DOD are both a government agency and a provider, and they do the most of the query, but because they do a broadcast query, so they go across our entire network, whereas most of our other providers do not. So we have a lot of exchange with the HIEs, between HIEs, and then with providers, and a lot of government exchange, and about 200 of our participants are part of SSA for benefits determination. So there's a lot of exchange, but the benefits determination is a smaller volume, but they do quite a bit of querying as well.
And I had a question with just looking at data from the N3C work that's come from multiple different EHRs or data sources, with the data harmonization and sort of quality checks, there's a lot of that goes on the back end so that we're able to use the data. Is that something as part of the TEFCA framework, or is that sort of the entity that's pulled the data? Do they handle that on the back end?
Well, I think it's going to be a combination of both. They do have that conformance testing, which means the right codes are in the right spot. But you say it always has to be this way, and then you look at it, it's like, this isn't the same. as that. And so, you know, I think it's a combination. We try to do as much as we possibly can up front. So it's like, okay, before you even can exchange with eHealth Exchange or on our QHIN, you've got to go through this content testing. But, you know, and we get complaints on certain participants, and then we go back and make them go through testing again and say, hey, listen, you've got to clean this up.
It's great, that back and forth quality conversation.
Exactly.
Thank you so much, Kathryn. This was just fantastic, and I think it's just, you know, abhorrent that you talk about you're talking boring. I think everybody was super excited to have you here today. So thank you so much for coming. I just thought maybe, you know, we have this wonderful collaboration that we've had with eHealth Exchange on the All of Us program. And, you know, I think one of the things that everybody's really, really excited about is just how can we use eHealth Exchange and the QHINs for and all the work that's going on in TEFCA to help kind of realize standardized data for research across all of these organizations, especially ones that are not part of academic medical centers that, you know, traditionally don't participate in research as much. And I'm just wondering if, I don't want to necessarily like, you know, belabor the project that we're doing with you all, but I'm just wondering if you could kind of speak from a more general perspective, the kinds of opportunities and questions that you've been getting, the kinds of strategic planning that you might be undertaking in order to support research usage, and just in general, this sort of like, you know, kind of fragile ecosystem that we live in now with bulk FHIR not being quite ready, FHIR payloads being different from different organizations, duplication of records, you know, coming through the network, and everybody having to rely on CCDA for the time being for the bulk of it. So just wanted to hear you brainstorm a little bit about some of that.
Yeah, and I mean, there's one of the issues that you brought up there is that deduplication of data, and some of the things that the QHIN standards are doing is that provenance, knowing where the data originally came from. You might like I live in Colorado, and there's 5 major health systems in Colorado, and I went to my MyChart from Epic and brought in all my data from the other organizations, and I had duplicates of all my lab results. You know, so the problem is very real, but if you know where it originated from, it makes that deduplication a lot easier. And so that's one thing that I think is gonna help. You know, moving to FHIR and getting people to do that, the bulk FHIR is really important. And, you know, again, I'll address some of that, but you know, that is coming because we know that there's a huge need for this. And but then from the perspective of, you know, how do you start on this? I mean, you know, what we have done, and with the CLAD, all of us, that is something that, you know, you have to find the right partners, right? Here's the people who are going to agree to share some of this, and how do you handle the legal side of the agreement so that, you know, who's going to sign that trust agreement? That's a barrier. And, you know, I think it's getting that first one, and then you get another one, and then you get another one. It's never as simple as it sounds. It's like everybody be willing to do this, and then, you know, when the rubber hits the road, it's more difficult. And so, you know, that's a challenge. But what we have found, and Stanford is a really good example of this. They say we never want to be first, but we always want to be second. And so, you know, it's like they don't want to be the one who's being the bleeding edge, but they'll want to be right after that. So there's a lot of organizations that feel that way. So I think getting that first start is really critical.
There's also one more question in the Q&A.
Yep. And that question is multiple questions. It says, how are the exchange results being used? In what format? Can receivers combine the exchange information into local EHRs directly, or is the information in HL7 format?
Yes and yes. It's in HL7 format, and it's typically, and it is ingested into their EHR. And so like Epic does a really nice job of that. They bring the data in. It's very easy for clinicians to find. It's part of their workflow. Other systems, some are really good and some are not. Obviously, I mean, there's a lot of organizations that use and Rhapsody or a Zen Consulting that it's kind of an integration engine, and they have built a pre-built solution that can accept those HL7 transactions. And so, but it's ingested because we don't supply a portal. We don't give flat files. It's an APIs that, somebody is interfacing with whatever system is going to use that data. Did I get all three of the questions? I think there were three.
I think, yes, some of them were like a combo, like the format.
Okay.
But yeah, that's interesting because looking at it, I'm a primary care doctor as well. So I have to click on an extra button to look at sort of the exchange data.
Yeah.
And it's not that easy.
No, it isn't.
Yeah.
It's better than some though.
Yes, yes. Being able to see it is more important. There's the first step, I think.
Yeah.
And then being able to do it in a workflow kind of way that goes seamlessly is another story. But yeah, this is great work and a wonderful presentation. Are there any more questions? The Q&A is empty, I think.
I don't know if the entire question got read, Rachel. So there was like parts to it regarding, having information, or the information is an HL7 message format. Just curious. So
Yep, I think it was
yeah.
the format between EHR and EHR and the query, and then also the HL7. I guess maybe the only question there, I'm sorry, was how are the exchange results being used? I did miss that part.
Okay, so it depends completely. And so once the data is part of your organization's data, then it can be used by your organization. People are going to be angry if you sell their data, that they've exchanged, when you say you're using it for treatment purposes. So that purpose of use is crucial. And so if people know that you're wanting this information for research, then, or if there's consent-based sharing of data, you just have to use that data for that. But after it's your data, it's your data. But most of the exchange is for treatment, and then that care coordination as well.
So somehow maybe there was some kind of a glitch going on with our Q&A, and some of the questions that were posted by the audience got marked as answered. So I apologize for that. Rachel, if you would like to take a look at the answered tab, there were two other questions from the attendee Shia. And I know we have only 4 minutes left, but if we wanted to kind of cover those.
Sure, no, thank you. I did see one question and then it disappeared. I think that question we were missing was, first it was a thank you for the excellent talk. And is there a place to have statistics about all the categories that are exchanged, for example, medication records or vaccination records?
No. And a lot of that is because we don't store that information. And so, we store metadata. So we know who exchanged with which other organization, and there's a timestamp, but it doesn't, you can't find Kathryn Bingman anywhere on eHealth Exchange. It's just, here's the transaction number. So if, for instance, if Stanford is exchanging with Manifest Medix and something errors out, they can say, here's the timestamp, here's the transaction number, what happened to that, why did it error out? So we don't have that data. We have toyed with being able to track some of that stuff as it's coming through. And maybe with FHIR, that would be like, okay, here's specific resources that you're requesting, and then you could know, you know, here's how much of each kind of resource is being exchanged. It's still early though on the FHIR stuff.
Okay,
Kathryn,
great.
again,
Thank you. And
yeah.
sorry about the Q&A technical difficulties.
Yeah, I apologize about that. Sorry.
Kathryn, again,
problem.
thank you. It's really, really not boring. And as a matter of fact, we would love to rope you in, you know, on a semi-annual basis to give us an update, because this is all so exciting. I think in the future, you know, we all fantasize about being able to move that data free and quickly and not have to have a specific agreement with each institution. And it's just not a, you know, so this, what you're doing is really great work. And thank you. Thank you for all the work you've done.
Yeah, thank you so much. And I agree, you're doing great stuff too. So we're all trying to make this stuff work more easily.
Right. Yeah.
Well, thank you,
so
everybody.
much, Catherine. Thank you
Thank
so
you.
much.
Thanks again. We'll see everyone next month. Bye.
Bye.